Like, we're dribbling down this. You don't need this anymore. You don't need. No, because you're all mic'd up, right?
No, they have two mics.
I can
hear me.
Exactly. That should be good.
I should just.
We see the microphone for the recording.
Yeah.
No.
You're recording? Oh, that's the, something.
It's like a little switch you push up.
I can't. I am a baby boomer. Say before.
There you go.
Hi, good morning, afternoon, good evening. Welcome to the world of innovation. So we'd like to thank the Perioperative Connect as well as the Adam and the chapter one. We used to be a different chapter, but we came to you, and such a wonderful thing. So the Perioperative Connect gave us the avenue to show an amazing quality. So all of this is about quality improvement that we have become our pathway in the VA. We do a lot of quality improvement, and hopefully the things that we would do will be very, it's not going to be very inspirational, like people that were the speakers that were here, but this is how we did things, and because we did it for the veterans. Anybody here, veterans? Hello. So we hit our objectives for today. So our first objective is to discuss the inception of a nurse-led innovation, and it's a nurse-led, truly a nurse-led innovation in VA Connect, and it's the PACU. You'll see from the discussion with my nurse manager, Denise Ormrod, you'll see how the pathway went. So, may not be like an ideal, but it was like a wonderful thing to see how we did it as a small community process in the PACU. The second objectives that we hit was to describe the process improvements started by the VA Connecticut PACU PICC team. Just remember, we did have a PICC team in the VA. So this is such a wonderful thing. And you know, I'm teary-eyed about this because I'm so proud of them. Identify the roles and responsibilities of the PACU PICC team. And we discussed how AAA, and I think everybody knows what AAA is, as the framework for the PACU team process. So, we have nothing to disclose. We're trying to get the federal government to give us money, and you'll come to learn that we really did garnered a lot of project. Denise, you like that? That was my brother.
Can everybody hear me? Okay, so thank you, Celeste. And thank you to all the veterans for your service. I do appreciate it. I'm a civilian, so working at the VA is very heartfelt. It's what I can give back to the veterans who have served our country. Let's see, so just going over some visions of VA missions. We have just did a whole thing here from VA Secretary McDonald and our mission here. No organization can succeed without values. Values match the mission. Our mission as the Department of Veterans Affairs is to care for those who have borne the battle and for their families, caregivers, and survivors. The core focus in our minds and our mission of caring and thereby guide our actions towards service towards others. We really follow the I care values. They're instilled in all of us. Even if you're not working for the VA, it's integrity, commitment, advocacy, respect, and excellence. A little bit about our organization. We do big nationally, so our strategic plans go from 22 to 28, our new ones. The VA empowers all employees to deliver high quality, whole health care that equips veterans, supporting their health and well-being by addressing the matters that matters most to them. It's really important for us to really look at the new services that they came out with, the new PACC Act, which is really patient driven. So we're really focusing on the patient as a whole. Our healthcare organization, specifically for my department and the whole hospital, we're a level 1 A1 facility, which is the largest, most complex facility a VA has. We are associated with Yale with their resident program, so we have residencies for pharmacy, surgical medicine, and physical therapy. We have 80 acute beds and 25 community living beds. Our operating room, as a big facility, it's only 7 rooms. One is dedicated to urology, so we're kind of small with 6 rooms. But the PACU is only 6 days. 6 days, we should have twice the days of our operating. So the flow in the PACU is pretty tight sometimes. And you know, surgery never leaves. Keep going. We also support our anesthesia NORA, we call it. It's a non-OR procedures that they're doing anesthesia care outside of the OR, whether it's MRI, endoscopy, CT scan, bronchoscopy. So our PACU nurses are really supporting not just the OR, but the rest of the hospital. As you know, the OR, we're very unique. We can do cases and our staffing methodology is based on what we're doing, whether it's 10 instrument trays or 2 instrument trays, 5 specimens, no specimens. It also goes by the skill mix of our staff, right? But they're able to do their competencies. And we follow those regulations. We at the VA, we support many different services. We do, I say, everything except bariatrics and transplants. But we do corneal transplants. We do a little bit of those. We do have new robotics program coming in. We do have the robot, and we are adding our urology robot, the aquablation, and an orthopedic total joint robot coming this year. So we're very excited for that. We do surgery Monday through Friday like a typical. We don't staff beyond 5:30, except for the call team, but we are 24/7. Our PACU functions beyond that, so they're open till about 8:30 at night. Let's see. We went through a lot of ups and downs, and during our downtimes, our nursing teams get very creative. It's good that they're very engaged and excited about different process improvements. They see things that could be better, and when we're really busy, you find that there's no time to really make those changes or make the suggestions or follow through. So we're kind of excited that we were kind of happy that we had those downtimes so that we can really focus on process improvements. Our PACU, as I said, with 7 rooms, we do support the anesthesia NORA cases. We also recover from cardiac cath, IR. We support 17 different services as are listed right there. And the PACU is the hospital PICC team, so they provide the peripheral insertions. We just started a couple months ago with the midlines now, so it's very exciting to see continued advancement and sustainability. These are just a few of the things that the teams go through every day with their documentation, their patient care, their ratios, you know, back and forth. So this was truly a nurse-led initiative. At the time, I was a nurse that was a team leader in the operating room. And I had to manage the PACU as well as far as the flow of patients. And I just happened to be sitting in a meeting where, you know, the data from the whole hospital says patients get stuck in the hospital for 5 days, 7 days, the length of stay. You got to figure out why. And I'm not listening because I'm a surgery patient, other than, do you hear surgery that they're not discharging patients? So I just overheard, my boss and we overheard that they're waiting for PICC lines. Interventional radiology is doing great procedures now, more advanced, and they don't have time to do the PICC. It's an easy thing. We'll do it last minute. So this was a team that we got together. It was the 2 nurses from the PACU. And they started this initiative to say, let's decrease the patient wait times for the PICC insertions and reduce the patient length of stay so they're not in-house. Then it won't stop our surgical patients. So we did go through a time where we didn't have enough beds and all the surgery, that's an admission. So to improve, the vision is to improve the veteran satisfaction as well as the patient flow. The nurses received comprehensive training, and they became the point of care providers instead of the interventional radiologists. Of course, always with the support of the interventional radiologists, because they were your subject matter experts at that time. Let's see. So before inception, it took the interventional radiology department at least 3.2 days just to get the PICC that was ordered from the day it was ordered. They would do their advanced procedures, try to fit the PICC in at the end of the day. It's 4:30, now they have to go home. So it was really difficult. So that ended up keeping patients in-house. Also delayed the patient treatment because then they couldn't receive that treatment. Let's see, most significant is the money that we saved. The cost, it's approximately $4 million return of investment, and it continues to be the nursing gold standard practice in our recovery room. The projects and the ideas come from the strongest places, our end users. This is the group of the team that we have currently. And like I said earlier, it did start with just 2 nurses training because you didn't know how many we were going to do. If you don't know what a PICC is, it's a peripherally inserted catheter. It's an intravenous catheter that's guided by ultrasound into the upper arm of the patient. The purpose is for prolonged regimens. So for chemotherapy, extended antibiotic, multiple IV medications, or even blood draws, that's difficult access. The risks of placing them, you're guided by ultrasound, so it could hit a nerve, you could have blood clot, infection, and maybe cause cardiac arrhythmias, depending on where the tip of the catheter is. So from the iData research, it says that 2.7 million peripheral inserted catheters procedures are performed each year. And the U.S. vascular access market values that at 4.8 billion, by 2020, and expected to reach 5.7 in 26. So the trends and the forecasts, despite the competition such as short, long, extended dwell catheters and central lines, PICC is still going to be one of the key components of and continue to be the gold standard. It's shifting, towards those lower failure rates, easier catheters, different types of insertion, better materials such as antimicrobial coatings. So PICC continues to change and continues to continue to develop into better products. So our problem and aim statement, which we decided as the group, the multidisciplinary group, project was to deliver infusion therapy access to veteran patients in a safe, timely manner. And our problem statement was that the IR department took 3.2 days from order of the peripheral line to actually placing the line. So our aim statement was to decrease from 3.2 days to 0.5 days, a half a day. So the day the order was placed, you can place that PICC. Again, nurse-led, this started in 2011. We estimated the cost about $3,000 for an interventional radiologist to place a PICC, and the cost for the RN to place it was approximately $300. I'm sure that has increased because all of our pay has increased and product again is also increased. So there was a total savings of $2,700 per patient. You can see that when you add, we did 600 appointments that one year. We've done a lot, so we saved a tremendous amount. Most significant benefits is that there's $4 million that's just coming back to the facility because you save that money, time, and X-ray. So this was, of course, a collaborative effort. It just doesn't happen with nursing. You have to pull all your stakeholders in. So we went through our national surgical office to make sure that this was something that our surgical program could sustain, our leadership in the hospital, with all approval, with all of those key stakeholders. The resources we used, of course, the national organization, we used the Infusion Nurse Society, of course, AOR and ASPAN for products that we may need to use, sterile techniques, and all of our members between nursing, physicians, oncologists, interventional radiologists, our radiology team, administrative officers, logistics, informatics, quality management, and don't forget to include your infection prevention so we can monitor any post-op infections or post-procedure infections. Our interested party are, of course, the stakeholders. It varies, and it's a lot. There's a lot of people involved to get this project started. We used a couple different data collection tools for process improvement. You want to have data. You have to support your decisions and your improvement projects with data. So this is just one sample of the data that we use to collect. And of course, when we did the IR data, we did not have the radiology time because they do it under radiology. But you always have to conclude the what, where, when, and why. What are we doing and why are we doing it? So we listened to the voice of the veterans. When we heard in the meeting that the patient length of stay and our patient satisfaction scores were not where we wanted them to be, we had to listen to the voice of the veteran. So just that little tidbit of information that the patient was waiting for the catheter to be placed, we started talking to those interventional radiologists. We started talking to the patients. Oh yeah, I'm still sitting here. I could go home, but I need a catheter so I can have my treatment at home. So we looked at scheduling, the scheduling process, how we scheduled between the IR and between the AO or the scheduler, and when the patients were notified. We found that the patients would actually be scheduled, oh, you're going today, and then at 5 o'clock they'd be told, sorry, we're not going to get to your procedure, try to do it tomorrow and discharge you tomorrow. So just trying to make sure we're listening to the patients. We want to remain veteran-centered, provide quality care, and really satisfy those patients. So those are the attributes that we really looked at. And then for our measurement, our metrics, we look at the procedure itself, training and education it would take for the nursing team to build that training and that skill set. Safety and quality. We want to make sure that we were really looking at that because we didn't want to provide care that was not at a high standard. And then, of course, teaching for the patients. How would that happen? Looking at our enhancement, our innovation, and success and sustainability, we're really sustaining great quality and fast care for our patients. So through the metrics over the years, we're still continuing. And the next steps, once we found that data we could improve, this is what we started to do. Did our fishbone, we looked at all of the processes that could affect this program, the manpower, the environment, the measurements. Do you do a patient on the floor or do you bring them down to the PACU where you only have 6 bays? So kind of had to weigh all the options and what would be the best. The unit workload. We found that our PACU on an average, we showed the PACU admissions with an average of 173 or 186 per month, and this was back then, which we probably doubled now, close to 250. We also showed in here the number of PICCs. So on the bottom graph, the orange line is the number of PICCs we're placing, and then the length of stay for patients. It shows how long the patients were actually in the PACU for our recovery, not for the PICC. So we can judge the timing of when we should be doing the PICC so that we don't slow down the flow of the patient's surgery or for any of the NORA cases. We also pulled the data for interventional radiology. Those are the cases that they're doing in an outpatient, and that doesn't include PICC. So you can see that they're fairly busy with no time, with only one room for an interventional radiologist to do procedures. So this PICC program was something that would really help them out and allow them to advance their practices as well. These are the number of the PICC lines that we've placed over the years. And you can see there's a couple barriers that we faced as a facility, but we were able to work through it. Our numbers went down because we didn't have surgical patients. So the inpatient flow changed, and that changed us. And we also started placing extended dwell catheters in 20. So our SICU nurses were placing the extended dwells, which didn't need, the patients didn't need a PICC. A lot of procedures we were doing, since we only had that one PICC team, we were placing PICC lines that we could have placed midlines if we had a midline program. So it took us until 2020 to get that program started. System redesign is always fun. It's something that everybody should be excited about. Every nurse and user, you see things that are barriers to you, and we want to make sure you have a voice so that you can speak about strategies to improve those processes. So brainstorming is always a good thing to do with even your peer, right? And then you bring those ideas forward. Plan, study, do, act. It's something that we do every day, right? We do it, study it, didn't work, test a change, let's go back or change it, tweak it so that it's different. Process flow map, input, process, and output, standard of work, visual management, failure modes, effect analysis, value stream mapping, and of course you have like the spaghetti map where you know where you're going. You think, I am running around in circles, what can I do better? Pursuing changes now. So we're trying to go to really improve the education and the way the nurses learn new procedures. So you do online courses for the PICC program itself. We had online modules from the vendor. We also have online through our TMS. We had a clinically guided hands-on learning for the ultrasound. We did self-assessments for each nurse after they went through those trainings to see what else they needed so that they had the support. They did peer assessment learning, feedback from the preceptors and then instructors. So knowledge and application. We're now able to do an ultrasound guided peripheral line, which is really good. It really helps, makes the patients feel a little bit better so that they're not poked 3 or 4 times, and you're getting the right vein and you're not hitting the nerves. Let's see, competencies. So to sustain this program, we have built competencies. We have a TMS training. We use the AORN techniques for sterile technique, gowning and gloving, and creating that sterile field. They use the waterless scrub so that they have good hand hygiene. And then some of the requirements. They have to know the anatomy and physiology. We all learned it in school, right? So now you have to really hone in on it. And create a mentor. Make sure you have a mentor that you can always reach out to. So when you run into a problem and you're looking at patients' data, history, and physical, you may know that or not know and have to reach out to that mentor just to throw things at the wall and see what comes back. So we follow our guidelines, you know, with our consent. We review the history and physical. We look at blood work, making sure that their blood levels are at a certain level. We set those standards so that it can be nurse-driven. It doesn't need a physician other than an order. We provide discharge instructions and education to the patients. We also provide education to the nurses on the floor in case they have difficulty with that line, managing that line. We went through new requests, new orders, so that we can streamline that order, and we knew if it was an interventional radiology PICC line or a nursing PICC line. So just knowing where you're ordering is really important. This is just a picture of our process map, how we flow from the actual order through preparation of the sterile field, as well as the consent, the timeout, and then the patient discharge. So just a nice flow map of how we do things. We do get a chest x-ray after we place the PICC line, although we could use the bullseye that comes with the system instead of now eliminate the chest x-ray if you get the bullseye with no arrhythmia. So we're working on that project next. So just a review here, the control plan and the return on investment. We started in 2011. And we calculated the $3,000 cost. And for nursing to do, it's about $300. So with 600 patients at 27 each, $2,700 each procedure, as well as the wait time from 3.2 to half a day, which is 5, and then our length of stay changed to 2.7. So that was really a win-win for everybody. Interventional radiology gets to do their advanced procedures, and we get to do advanced procedures as a nurse. Control plans. When you do process changes, you have to make sure that you have control plans in place so that you know you're meeting those metrics. We're measuring for success rates, infections. We're watching sterile technique, making sure that everybody is compliant with the SOPs that we've developed. And we do so many per year so that they can maintain that skill, even with our decreased numbers. So making sure you have all that in place will allow your program to stay and remain successful. And remember, you be a good listener. Listen to what your team is saying to you and what your nurses are saying, what the patients are saying, so that you can actually implement a good strategic plan for a sustainable program. And Celeste is going to finish up. You're in big trouble.
So framework. I have to apologize. Oh, sorry. I have to apologize. I have to switch classes. I actually ventured on playing a pickleball. And I fell down. So I had my progressive lens. So now, because I'm so cheap, I have to replace it. So I'm gonna go switch. It's like a switch. Okay, so now I think everybody knows about it's not a bullseye. So AAA. This was actually IHI, or the Institute of Healthcare Improvements Initiative. We were in, so a lot of things happened. The time even before we had the PICC line instated, or the inception of the PICC line. So as a framework, just like anything in school, when you always ask for, when you're asked by your teacher, what is your theoretical framework? We choose this because we had achieved what the AAA had asked us to do at the PICC line, that program that it's a nurse-led initiative, had completed using this kind of platform. So by design, the access to healthcare organization is one important choice utilized by our veterans. This is to address their challenges, to find a valuable place to conquer their difficulties after deployment, and as a result, continue to experience a sustainable quality of life. Because in this process, it's always a given that it is a place for curing and caring. So the operating room plays a big factor in this population of health, cost, and patients and the staff experience coming into this expertise. Improving healthcare quality has always been in our radar since 1999. So AAA was one of the main foundation that completing all those aims that were specified. Actually, this became quadruple, and it's progressing to the quintuple. Say those words. So improving population health, improving patient and the provider experience, and reducing the cost of healthcare were the underpinning of this initiative. And how do you do that? You don't have staff. Escalating costs of healthcare. You hear from everyone from leadership. Oh, we are this, we are $1 billion deficit. Oh, we have a thin margin that we are experiencing. So how do we do this? This is a radical move, actually. I see that the whole thing that was developed by one of those learned people Dan Roy, who I met. So really very influential about this, very dedicated, making sure that the patient population is the center, center and the focus of all this. So don't fall asleep. Let's go for history. And I'm not a historian, believe it or not. So who remember what happened in 2009? Someone sleeping? No, just kidding. Who remember 2007? Who remember that year? Oh my gosh, you're so young. It's okay, Charles. Who remember 2007, 2009? So I relate this on the whole thing about the PICC line because 2011 was the start of our program, that nurse-led initiatives. So this triple aim was an idea that circulated and thinking that, wait, we have to do something, which is actually, to me, it was laughable. It was not radical. It was something that we've always done. It's always something that's like the foundation of what we do as nurses, or even as those doctors who are, or surgeons that are in the healthcare, or even the leadership team, right? So this became like, wow, this is a new concept. But to you or to us, it's always been there, right? True, false, yes? Yes, so this is our foundation. This is what we do every day as we take care of our patients. So what happened during that time? Financial crisis. Remember all your money? That was this looming event that there's gonna be a crash, financial contagion. Remember those times? Yes, maybe you were still young. Then I remember that because I had to go and ask my husband, do we have food for grocery? I'm just kidding. Okay, so during the time, there was the liquidity crisis, right? So you'd hear about the people investment are being taken out of them, whatever. There were so many things that they were actually having this whole, how do you call that? The withdrawal of deposits, all of those things. What happened other than that? You remember the housing crisis? 10 minutes, okay. So there were crises after crisis during the time. So in a certain community of learned people in healthcare, leadership, and experts, AAA becomes one of the best things in life. So it refers to the pursuit of improving a patient, which is a very ambitious purpose, experience of care, improving the health and of population, and reducing the per capita cost of healthcare. So everything in here is patient focused. But then again, we needed money, right? And all this vulnerability, uncertainty, ambiguity, and chaotic life is becoming a crazy thing. It was very chaotic during the time. So 2011, fast forward. Before that, the Obamacare. Yes, Affordable Care Act. Everybody's focused now on what are we going to do when it comes to patient. We have no money. We have all these different things. The regulatory agencies are giving us all these different things. How do we achieve this? So there were a lot of things, earthquake, a lot of geopolitical things that happened. I think you remember there was the Obama thing. I mean, the Osama bin Laden. That was another thing that happened. So there were a lot of transformation, and this was the best thing that happened that created a revolutionary idea that got conceptualized and got into this whole thing that everybody is now going to use as a framework. So that's how we use the AAA. So now, how does this apply to the veterans? Achieving the IHI triple aim. Now let's quadruple aim. Eliminates the delay in treatment, as Denise mentioned about the length of stay, and then the decrease in cost, which is for us X-ray, the workload, RN versus proceduralist, and then reduce procedure time, the patient experience. patient satisfaction was optimized. So how does it become sustainable? We see it in a perspective that we're giving service and this is what they deserve after what they had experienced. And I know this is not just about the veterans, it is applicable to every patient that we take care of. So for sustainability, this is vital for our veterans patient experience and timely treatment, decreasing inpatient length of stays, which is a very repetitive thing. So our success story continues to grow with succession planning, comprehensive training. We have all this implant tracking system that we created and continued competency validation. They actually, every year they have to complete 10 minimum of completion of insertion of their gland. This was explained by Melanie, so I'm not going to repeat it, but for us, for the nursing practice, evidence-based clinical expertise should be patients' preference and values, and of course the R word that people like us to venture in. So we're in this process of shared governance, this shared decision making, which is very important for our patient. They have to have a say for this. I don't want this procedure. This is not going to help. But it just doesn't stop there. You have to make them realize through education, through explanation, through empathy, through sympathy, and all those kind of stuff in order to have them to make a good decision. And that's actually theirs as well. Now, we love quality improvement in the VA. It's like embedded in our system. Everything has to be on that process. And actually, it's a very structured process when it comes to this quality improvement. And I think many of you knows the Donovan framework, which is structured process and outcome. So that's the whole thing with quality improvement. Of course, your favorite nursing research, you can get out of that area because that is the only credible, verifiable, translatable, and things that you can refer, and then you can speak through to the veterans why they're receiving this treatment. So we do a lot of, and every institution that are on their migrant journey, on their redesignation, 6 times redesignation, we go through all these different things. To us, high reliability, HRO, you know that system, that it's always going to be, the Joint Commission is so gung-ho with this, commitment to zero harm, and high reliability organization with their principles. You should have your leadership engagement. That's what we have so that we can be successful to become an HRO organization. Culture of safety, I think that has become an over and over concept that's being discussed by everybody because adverse event is the 3rd highest contributor of death from heart attack and cancer, and we are number 3 for that. So just part of the HRO is the robust process improvement, and of course safety and quality of life. Quality of life is very important, and that's very important especially for the veterans. It's very challenging to come out of deployment and come out and see that you cannot really function well as expected to what you had done before that deployment. And those people who go through the journey of migrant vaccination. So this is how VHA goals, supports VHA goals becoming a high reliability. It's about the veterans, commit to zero harm, learn, inquire, and improve, respect for people, and clear communication. And that's how the team, the PICC team, had completed and had, that's why we have become sustainable in our project. And then this endeavor. Those are the people that we have. They were missing 1 or 2, but we actually presented this poster to San Antonio earlier this year. And thank you. One more thing, I have time. I just want to read to you something. Wait a second. This is about, this is Donovan's, what he said to us. Now I'm going to change my Oh, never gonna play pickleball. That's pickleball, right? Pickleball. See, I'm a Filipino. I'm sorry. So I don't have any more of this. So it's gone. So I will do it. So he said, this is gonna be a gem. He was diagnosed with prostate cancer. He said that, and very important because this one actually touched me. Healthcare is a sacred mission, a moral enterprise, and a scientific enterprise, but not fundamentally a commercial one. We are not selling a product. We don't have a consumer who understands everything and makes rational choices. And that's included him. Doctors and nurses are stewards of something precious. Ultimately, the secret of quality is love. You have to love your patient. You have to love your profession. You have to love your God, no matter who they are. If you have love, you can then work backward to monitor and improve the system. Thank you.